Welcome to What Healthcare Providers Need to Know About 2019 Novel Coronavirus. This is Dan Campana from the Emergency Nurses Association, and I'd like to thank you for joining us today. This webinar is a collaboration by the Emergency Nurses Association, American College of Emergency Physicians, and the American Association of Medical Colleges, along with the Centers for Disease Control and Prevention and the National Ebola Training and Education Center. We are excited to welcome today's presenters. Dr. Bruce Ribner from NETEC, who will provide an overview of coronavirus disease 2019. Kate Bolter, lead nurse for the Nebraska Biocontainment Unit, is here to discuss personal protective equipment, the Identify, Isolate, and Inform concept, as well as information about waste and disinfection. To talk about treatment and care, we have Dr. Anish Mehta, Associate Professor in the Division of Infectious Diseases at Emory University in Atlanta. Dr. Alex Isaakov, Professor of Emergency Medicine and Executive Director for Emory's Office of Critical Event Preparedness and Response, will review EMS and patient transport. And today's moderator, Sharon Van Arsdale, Program Director for Serious Communicable Diseases at Emory, is here to give everyone details on NETEC Resources. At the end of the presentations, our panelists, as well as Ryan Fagan from the CDC and Shelley Schwedhelm from NETEC, will be happy to answer a few questions you might have. You can submit your questions using the webinar's chat function. Now I'd like to turn it over to Sharon to get things started on this important topic. Sharon.
Thank you very much, and I appreciate everybody joining us today. It is an honor to have this joint webinar. Just wanted to go ahead and provide you guys a little bit of background on what is NETEC. So the National Ebola Training and Education Center, or NETEC as we call it, was created in 2015 through emergency supplemental funds appropriated to the U.S. Department of Health and Human Services, specifically to the Assistant Secretary for Preparedness and Response and the Centers for Disease Control and Prevention. It is a collaboration between Emory University, Nebraska Medicine, and New York Health and Hospitals Bellevue, with a mission to increase the capability of the United States public health and healthcare systems to safely and effectively manage individuals with suspected and confirmed special pathogens. While Ebola is in our name, NETEC is focused on preparing public health and healthcare systems to manage any special pathogen of concern, like this novel coronavirus we are going to be discussing today. We apply what we have learned from Ebola preparedness and translate it to everyday patient care. So NETEC really has 4 areas of work. One area is through consultations that we have on-site assessments and consultations with healthcare facilities. We do education through in-person and online offerings. We have online resources and virtual assistance at www.netec.org. And we have a research network across 10 regional Ebola and other special pathogen treatment centers. Now I'd like to transition over to a little bit about this coronavirus with Dr. Bruce Ribner.
Yes, I'd like to briefly review for you the epidemiology of the current outbreak. Starting first with the family coronavirus. The coronaviruses were named for the solar corona-like appearance under electron microscopy of the viruses in this family. They're a prevalent cause of the common cold. They're a family of viruses which has 4 genera, although most of the activity over the last 2 decades has focused on the beta coronavirus genus. This genus includes the SARS coronavirus, the agent responsible for the SARS outbreak, the MERS coronavirus, the virus responsible for the MERS outbreak, and the most recent coronavirus, which started off being labeled 2019 novel coronavirus, and now courtesy of a committee of the World Health Organization, has been named SARS coronavirus 2 because of its close similarity to the SARS coronavirus. You will see some confusion because the disease which is caused by SARS coronavirus 2 has been named COVID-19. And so you will frequently see some confusion in terms of whether COVID-19 represents the illness or the virus. But in fact, it is the correct name for the virus, for the illness at the current time. On this graphic, we see several members of the coronavirus family. On the left side, you will see the 4 coronaviruses which have been well documented to cause a large number of common colds. And on the right side, we see the coronaviruses which have been of great interest over the last couple of decades, the SARS coronavirus, the MERS coronavirus, and now the SARS coronavirus 2, which causes COVID-19 disease. Looking briefly at the outline of the current outbreak. On December 31st, the World Health Organization China Country Office was informed of cases of pneumonia of unknown etiology, which were detected in Wuhan City, which is in the province of Hubei. Within 1 week, a Chinese virology laboratory, also in Wuhan, was able to identify the virus which they felt was most likely responsible for this outbreak, which was then labeled a novel coronavirus. On February 17th, or yesterday, the outbreak had already involved more than 75,000 individuals, far more than the 8,000 to 9,000 that we had during the SARS outbreak. And unfortunately, over 1,800 individuals have succumbed to this viral infection, again, more than twice the number who succumbed to the SARS outbreak. While there was initially some confusion as to whether this SARS-CoV-2 coronavirus could be transmitted person to person, it is quite clear now that the major transmission occurring in the world today is by person-to-person transmission. This graphic shows you the activity of the coronavirus outbreak in Southeast Asia. As you can see, the major activity remains in the Wuhan area, although there are clearly many other areas of activity both within Eastern China and in other Southeast Asian countries. And this is a global map showing the many countries which have been involved in this outbreak to date. Now, the last update on the pages of the Centers for Disease Control lists 15 individuals in the United States known to be positive for the SARS coronavirus 2, 392 to be negative, and 60 to have testing pending. But as many of you know, over the weekend, 14 additional infected individuals were brought back to the United States from Japan. And so the next update of this page is clearly going to see a dramatic increase in the number of infected individuals currently in the United States. As the outbreak emerged, travel advisories changed over the weeks. On January 21st, the CDC issued a level 2 travel advisory, which just means be cautious. Approximately 1 day later, the Chinese health authorities issued travel restrictions to and from 8 cities in Hubei province, including Wuhan City. On the 25th of January, the CDC issued a level 3 travel advisory for Hubei province, China, which basically means only essential travel should occur to this area. On January 27th, the CDC issued a level 3 travel advisory for all of China. Again, avoid non-essential travel. On January 31st, the US government announced a national public health emergency, no non-essential travel to China, and a 14-day mandatory quarantine for returning travelers from Wuhan. And then on February 2nd, a level 4 travel advisory was issued by the US government, basically saying no one should travel to China or to the Wuhan province area, and anyone coming back would have their activity severely restricted. Now, there's been some confusion in the press between the terms isolation and quarantine. So just to review these, isolation is the separation of ill individuals who have a communicable disease from those who do not have that disease. It restricts the movement of ill persons to help stop the spread of these diseases. And one example that we're probably all familiar with is the airborne infection isolation of patients with active tuberculosis to prevent others from acquiring that infection. Now, in contrast, quarantine is the separation and restriction of well persons who may have been exposed to a communicable illness, and the monitoring of these individuals to see if they become ill. They may have been exposed to a disease and not know it, or they may have the disease but not show symptoms. And again, quarantine can help limit the spread of a communicable disease. In an effort to help us identify those individuals who warrant special attention because of potential infection with the novel coronavirus, the Centers for Disease Control has established criteria to guide evaluation of persons under investigation. Firstly, we have individuals who have fever or signs or symptoms of lower respiratory tract illness. If they have had close contact with a laboratory confirmed patient who has been infected with the 2019 novel coronavirus within the previous 14 days. The second category would be individuals with fever and signs and symptoms of a lower respiratory tract illness and a history of travel from Hubei province, China, within 14 days of the symptom onset. And finally, we have individuals with fever and signs or symptoms of lower respiratory tract illness, ill enough to require hospitalization, together with a history of travel from mainland China within 14 days of symptom onset. I will now transfer this discussion to Ms. Kate Bolter, who will discuss identify, isolation, and inform.
Thanks, Bruce. Thanks, everybody, for being on this webinar. It's a great pleasure and very humbling to be able to give you this information. Next slide. Okay. So the first thing that we want to show you is that the CDC has provided us with guidelines on how we can manage these patients. And it does bridge on the isolation or the identify, isolate, and inform guidance that was produced back in 2014 when we were taking care of Ebola patients. Next slide. The flow chart, as you can see, getting a patient to isolate, getting a mask on them, and wearing the appropriate protective equipment. But we're going to go into that into a little bit more detail. So next slide, please. Great. So one simple thing that everybody needs to be thinking about is how we can respond to patients who present to our EDs with infectious diseases. The identify, isolate, and inform is already mentioned, where we need to identify very quickly that a patient may have an infectious disease, isolate them so that they're not passing that infectious disease on to other people, staff, patients, or anybody else in the hospital. And then informing the right people so that we can get resources put in place to help you with that. So as patients do arrive at your facility, it really is very important to have a process that will allow you to identify the potential for them having an infectious disease and then rapidly mitigate that potential of spread. That involves, first of all, really asking if they've got the symptoms. Do you have a cough? Do you have a fever? Is this something that can transmit infections to other people? Once you've determined that, then get a travel history, because then that travel history will give you an idea on where they may have acquired that infection. So, if a patient has visited a country that doesn't have the COVID-19 infection, then they probably are not at risk for that. But if they have just come back from Wuhan, China, then that would definitely make you think that you need to put them in isolation. However, no matter what the infection is, it is advisable that, if somebody does have a cough, get a mask on them, because, even if it's the common cold, nobody wants to catch that. Once you've got a process in place for identifying, you really then need to look at all the ways that a patient can enter your facility and implement that process at all access points. And you can see on this slide some of the access points that you may have at your hospital. Your emergency department, I mean, that's a very common place for people to come for emergency help. but there's also clinics and ambulatory care centers. And then think about how are those patients going to arrive? Are they going to walk in by themselves? Or are they going to be brought in by other persons? And what are you going to do with those other persons if that is the case? If they come by ambulance, they may have been pre-identified as a PUI en route, but they may not. They may not get identified until they actually arrive in your emergency department. And then, of course, there's the conditions that we need to be prepared for. We have patients who come to our EDs that are non-emergent, but then we do get some that are critical. And then, you know, what are we going to do as well if, you know, we have a PUI or a suspected PUI who comes to us by ambulance and expires on the way. Next slide, please. So one simple measure that really can facilitate us getting a patient identified quickly would be to put signage up. And that really works for two things. That can help us identify, and it can also help us get them in isolation very quickly in some ways. So a person walking into the emergency room, they might not know that they've, you know, are at risk for having COVID-19 or any other special pathogen disease or any other infection, but they will know the symptoms they're having. So if you have a sign up that says, you know, if you've got a cough or if you're sneezing, then please put a mask on, then, you know, they will follow that. A person who puts that mask on before walking into your emergency room, it will greatly reduce that door to mask time and reduce the chance of that disease transmission. Next slide, please. Next slide. Okay, so isolation. So for COVID-19, the CDC recommends the use of standard contact airborne precautions with the use of eye protection. Some patients that you suspect may have this condition should be placed in an airborne infection isolation room if you have one available. If you don't have one available, then keep them in a room with the door closed and keep that mask on the patient, just so long as they can tolerate that. Also implement contact precautions and definitely eye protection for healthcare workers who are directly interacting with that patient or they're in the room with that patient. Next slide, please. Inform. As I mentioned earlier, inform is a very important feature of the identify, isolate, inform process. By informing, you are going to be able to activate the resources that you're going to need to take care of that patient. That would be things like getting the right lab tests by the right people and things like that. But inform can also come in two buckets, so to speak. You've got your internal communication. So you see this sign or list on the right-hand side. These are the people that you work with. They all need to know what's going on to be able to implement processes that are going to help get this person either into isolation or get testing done, whatever the case is going to be. So look at this list. Think about who is it in your emergency department that needs to know, but beyond your emergency department, who else? Your infection control nurse, your administration, people like that in the hospital. They're very, very important to the care of this patient. Next slide, please. This is a list of the external communication that will likely go on, and every facility is going to be different, and it's all going to be based on your own CONOPS for your state and your region. But do make a list and make sure that you make a note of who the people are that are going to make this calls, because the last thing you would want to happen is having a patient walk into your emergency department and then you think that somebody else made the calls when nobody did, and then a lot of time would be wasted in that respect. Next slide, please. we're going to look at personal protective equipment right now. So as I said earlier, the CDC has recommended standard contact airborne isolation with the use of eye protection. And in this photo here, you can see what that looks like. So we have a face shield that is going to protect a person's eyes or protect our mucous membranes. The N95 respirator to protect their airway. The isolation gown. This is a standard isolation gown that can be put on very easily. And number 4. And lastly, a pair of gloves. Just make sure that when the gloves go on, they do cover that skin bridge between your wrist and the sleeve of the gown. So make sure it goes on very well. Next slide, please. So using the CDC guidelines, NETEC has actually produced an education that can guide people through the process of how to put on and take off the PPE. It's a step-by-step, how you put on your PPE will greatly affect how you can take it off so that it comes off in the correct order to prevent self-contamination. And like I said, these are based on CDC guidelines. And next slide, please. When you're in PPE, it's really important to behave well. So make sure that you're performing hand hygiene at all the moments that you really should be, but it's before touching the patient so that you're not passing something onto the patient, before a clean or aseptic procedure, after touching the patient, after body fluid exposure, and after touching the patient's surroundings. Very important. And the CDC and the World Health Organization both have excellent ways for you to, or systems for you to follow to do good hand hygiene. And I think one of the other important things about hand hygiene is it should not take any less than 20 seconds to do that. Next slide. Okay, so I am going to pass this over to Anish Mehta, and he's going to talk about treatment and care.
Hello, thank you, Kate. Yes, we'll take the next few moments to talk about diagnosing, treatment, and care of suspected or confirmed patients with COVID-19. So starting with some laboratory testing, first and foremost, it's really important if you have any concerns for the novel coronavirus or COVID-19 to contact your local laboratory and your local public health agencies so that they're informed that you are looking into testing for this disease. Testing currently is only available at the CDC in a few select laboratories around the country. We do expect in the coming days and weeks to have more laboratories that are able to do this test that will greatly reduce the turnaround time. But the CDC is very active in doing this testing when requested and communicating those results very rapidly to the testing facilities and public health agencies. We don't know if the coronavirus, the novel coronavirus, will be present in upper respiratory secretions at all times. Therefore, it's recommended to get both nasopharyngeal swabs and throat swabs, but when possible, to also get lower respiratory samples, which can be sputums, induced sputums, mini BALs, or BALs when available. Also requested are serum samples so that additional testing can be done. For those who are used to using our multi-targeted respiratory viral panels, such as the BioFire, GenMark, or Cepheid products that are currently available in many hospitals in the country, none of these tests have cross-reactivity to the novel coronavirus. Therefore, if you have a positive test for coronavirus on these assays, it will not be COVID-19. And importantly, do not have your laboratories try to obtain viral cultures. That should only be done in specialty laboratories such as the CDC. One essential in doing this testing, and this is true for all respiratory viral testing, is to make sure that you're using the correct equipment, such as a predetermined synthetic fiber swab for respiratory viral testing, And very important, it must enter in through the nasal cavity to the posterior nasopharynx to make sure that you have the appropriate sample taken to improve the diagnostic sensitivity. So recommendations for clinical care, again, if you think you're caring for someone with COVID-19, it's very important to let your local infection control professionals know, as well as public health, both local, state, and federal public health agencies. Important to note, mild disease does not necessarily require hospitalization. Again, you can work with your public health agencies to ensure that those individuals get the appropriate care and isolation without necessarily being in the hospital. Care is the same with COVID-19 as other viral pneumonias, such as influenza and RSV. We need to be able to provide oxygen support, invasive oxygen support if needed, monitored fluid administration, both oral and IV, provide nutrition and electrolytes for the patients, and then consider antibiotics if there's signs of secondary bacterial infections or bacterial superinfections. Currently, there are no known therapeutics or vaccines available, but there are many experimental options that are being considered at this time that may be available in the near to distant future. One recommendation that has come from colleagues around the world is to avoid the use of corticosteroids in patients with COVID-19, as they may cause worsening of their lung disease. We should learn more about this in the coming weeks. Taking a few minutes to talk about the clinical presentation. Currently, the incubation period is thought to be around 5 days on average, but can range from 2 to 14 days. These patients do present with a constellation of symptoms that are very common to other viral diseases. So the vast majority of them present with fevers. Many have cough, and also many have myalgias and fatigue. On presentation, there are some laboratory abnormalities that have been reported to be common, and that includes leukopenia, leukocytosis, so high levels of white blood cells, lymphopenia, and interestingly, in about 1/3 of patients, elevated AST and ALT levels. Chest imaging have shown bilateral involvement in many of these patients, with many areas of consolidation and ground glass opacities reported on chest imaging, including CT scans. Just to quickly review the clinical course of these patients, interestingly, the majority of patients, up to 80%, have very mild illness or mild illness. We have seen severities range from this mild illness to severe and even, unfortunately, fatal illness in some patients. It has been reported that the clinical deterioration often occurs in the second week of illness. And approximately 1/3 of hospitalized patients are requiring intensive care. We have seen ARDS develop in 17 to 29% of these hospitalized patients in China. And secondary infections have been reported in approximately 10%. Invasive mechanical ventilation has been reported in up to 10% of hospitalized individuals. And there has been use of ECMO in certain hospitals that are caring for these patients. With that, I'm going to turn it over back to Kate Bolter to talk about waste and disinfection measures.
Hi again, everybody. If you know me, you'll know that this is one of my favorite subjects, talking about waste. Next slide, please. Okay, so a concept that, or a fact really, that came known to all of us during 2014, 2015, when we were taking care of Ebola patients, was getting to learn about regulated medical waste and how it's split into 2 different categories. So we've got category A, which is material that's contaminated with a substance that if you come in contact with it could cause a permanent disability or life-threatening or fatal disease. and otherwise healthy humans or animals. And then we've got category B. So notice that category B is still under regulated medical waste. And this is waste that's not in a form generally capable of causing permanent disability or life-threatening or fatal disease. Next slide, please. So as we are looking to care for patients with COVID-19, this waste will be classified as category B regulated medical waste. Another term that we're all very familiar with is that this is biohazard waste. So it's standard procedures, so follow what your facility normally does with biohazard waste. Of course, you may want to speak with your environmental services folks and just make sure that everybody is on board with the process. Next slide, please. When you're packaging by category B waste, or any waste really, it should take place where waste is being generated. And staff should be wearing appropriate PPE when they're handling waste at any time. Waste containers need to be lined with a leak-proof biohazard bag that's capable of holding the waste. So sometimes there's, I've heard discussion on how thick a bag should be. People have asked me that question. But what it really needs to be is it needs to be strong enough to hold whatever it is that you're putting in there. The bags also should be large enough to line the container that you're going to use, and they should also overlap that container, as you can see in this photo, because that will greatly facilitate you being able to close that bag. And if you can, try putting the waste into the container without creating an air pocket under it. And what I mean by that is don't put the bag in so that when you put something heavy into that trash can, that it will sink down to the bottom or push the bag down to the bottom. So make sure that you completely line that waste container to avoid the possibility of aerosolizing anything from that bag when trash is being put into it. Next slide, please. Other considerations. So as I've already mentioned, that container should be close to where it is that you're using it. Don't fill them more than 3/4 full, because by doing that, you're going to make it difficult to tie off the bag. And you may also make it too heavy to be able to handle it safely. As always, caution should be given to avoid sharps being inadvertently placed in that waste container. And in some cases, sharps are not always just needles, that there's other items that we can put into a waste container that may be considered a sharp. Things like if you're doing that nasopharyngeal swab, when you break that, the shaft off, when you're putting it in the vial, then, think about that. Think about, can that maybe lead to a sharp or somebody getting stuck in some way. Also place your waste in the containers gently to prevent any kind of aerosolization of the contents. And never ever compress that waste to make more room. That does two things. One, it could aerosolize contents, or it may cause you to get hurt by a sharp that's in there. Next slide, please. When you are removing the bag from that waste container, there are several ways that you can do it to make it safer for yourself. So for example, remember I said that if you have the bag, you have it overlap the waste container, that will help you, because what you can do then is you can squat down next to that waste can, and by squatting down, what you're doing is you're taking your face to the side of that waste can, not over it. You grab two corners and then you twist before you even begin lifting that waste, so that when you lift the waste, you're going to grab it by the twist that you've just created, and you're sealing the bag off as you're lifting it out. So anything that's going to settle and maybe cause some sort of aerosolization, it's not going to be able to escape out of that bag. Next slide, please. The closure method that the Department of Transportation want us to use needs to be a method that when you invert that bag, nothing will leak out of it. And there's two methods that you can actually use. One is called the balloon knot, or sometimes it's called the overhand knot. When you do that, you really need a good amount of neck on that bag to be able to wrap it around your hand and then slip the end in to create the knot. Be careful when you do that, not to get your gloves caught in it, because that could lead to a breach in your PPE if you pull your gloves out sharply. The other method is the gooseneck. So you can see in this picture, it's wrapping the neck of that bag to get a long enough neck to bend it over, and then you're going to do something to keep it in that position. Some people are using zip ties. Be careful with zip ties though, because that could cause the bag to puncture in the right circumstances. Or you can use tape. That's also a good method to be able to keep that. Some people use rubber bands, so they'll put a rubber band on that and make it tight enough to keep it in place. And as you can see, if those bags were to be inverted, nothing's going to leak out. The picture on the right, I think it's kind of funny that we're saying not acceptable, but this is called the bunny ear way of tying the bag off. That's not acceptable because unlike the other two methods, things can leak past the bag if you tie it in that way. And that's really why you need that extra overhang to help you to close that bag. Next slide, please. So disinfection, and how are you going to disinfect the area? So you have a patient who comes in, it's unfortunate that, what you see on the right there doesn't happen. He doesn't just leave big blobs of coronavirus where you can actually see it. So it's all going to be hidden. You can't see, so you're going to have to clean everywhere where that patient may have contaminated. I did read a study recently that said that coronaviruses can persist on inanimate objects for up to 9 days. So it's really important that we do clean, and the CDC does have guidance on how we do that. Next slide, please. One of the things that you can consider is, can the area be locked down and sequestered, especially if you're taking care of a PUI. So that's someone that you don't really know that they have the disease, but you think you've got a good suspicion that they do. But can you just shut down that area and sequester all your waste and everything until you know? And once you find out that they don't have it, then you just use your normal procedures and you clean. If you find out that they do have it, then in that case, then making sure that you're wearing the correct PPE and decontaminating that room. You also need to decide on who's going to do that cleaning. Is it healthcare workers, or is it going to be your environmental services department? Either group needs to be trained. They need to know how to wear the correct PPE and how to behave in it, and also how to do the job. One good thing or a tip really, is to create a cleaning checklist for both routine and terminal cleaning. So routine cleaning is on your day-to-day or hour-to-hour even care of the patient. Where you have a checklist that says, clean the bed rails, clean the door handles, the ledges, things like that. And then, of course, your terminal cleaning that goes into great detail on how you're going to terminally clean that room so that it's safe for other patients to go in afterwards. And then there's also, the adjunct options. As I already mentioned, shutting the area down. It's time. Viruses do die eventually. But, I don't think anybody's got the bandwidth to be able to, close a room down for 9 days. So cleaning is going to be very important. You can use ultraviolet light. A lot of facilities now have the ultraviolet light, I'm going to call them machines, my lack of knowledge on what they really should be called. But, those work very well as well. And of course, some facilities have got vaporized hydrogen peroxide that they use for disinfection. Next slide, please. when you are terminally decontaminating an area, really important to wear appropriate PPE. Although the patient won't be there at that time, there could be fomite transmission that can go on. Any equipment that's going to be cleaned and disinfected, make sure you get rid of the disposable parts first. Pull that all off, get it in the waste, and dispose of it appropriately. Remove all waste. So when we get ready to decontaminate our rooms, the first thing we do is we remove the waste and we deal with that. Get rid of bed linens. If you've got privacy curtains, it's very difficult to clean those in place, so you're going to have to take them down. The surfaces can be cleaned using cleaning products. And remember, you do have to clean before you disinfect. You got to get rid of, whatever it is that's causing a surface to be contaminated. And then after that, you disinfect the surface using an EPA approved disinfectant that's known to be effective for that particular pathogen. And then create and adhere to your facility protocols. Next slide, please. Equipment that you're using in a room, the CDC does recommend that it's dedicated. So if you can dedicate, let's say, an X-ray machine to your area where you're taking care of those patients, so that that's the machine that's going to be used on all your patients with that same disease, then that's probably a good idea, because then it's not going back into the other population. But if you can't do that, because not everybody's got the bandwidth to be able to just dedicate equipment to certain patients, then make sure that it is cleaned and disinfected. And there's no one way that's the right way, except to say it should be, according to your manufacturer's instructions and your facility policies. Next slide. So we're going to pass it over now to Dr. Alex Isakoff, and he's going to talk about transport and EMS.
Thank you, Kate. So for background, I'm an emergency medicine and EMS physician. Next slide, please. So I know many of you are very familiar with the emergency medical services system. Really, emergency medical services system could interface with a possible COVID-19 patient or a patient that's confirmed to have COVID-19, either because they're involved in the dedicated transport or interfacility transport of those patients, or at a time when there may be COVID-19 in a particular community, then through the 911 system. And the comments that I'm going to make should be applicable to both of those communities, both emergency medical responders in the 911 system, as well as those that may be dedicated to an interfacility transport mission. All of my comments have been referenced to the CDC's interim guidance for emergency medical services systems and 911 public safety answering points, which can be found on the CDC website. The overall objective for emergency medical services clinicians in interacting with any patient, and these patients in particular, is to provide good supportive care for the patient while protecting the healthcare worker, both those that are the EMS clinicians and those clinicians that would be receiving these patients at a hospital or assessment facility. And of course, there's always that responsibility and duty to protect the bystander or the general community. Next slide, please. And this is largely done by developing and implementing environmental controls, administrative policies and work practices, and then having an adequate amount and the appropriate safety equipment available, all with the goal of preventing transmission of biological agents to personnel that might come in contact with it in their environment. This is considered called the hierarchy of controls. And the hierarchy of controls are actually, with regards to their effectiveness, probably would yield the greatest effectiveness if we can engineer our environment or develop policies and procedures that would decrease the likelihood or eliminate the likelihood of exposure to infectious bodily fluids. Ultimately, the safety equipment that we have is our last line of defense in protection from those infectious bodily fluids. But implementing this hierarchy of controls is important for the protection of the healthcare worker so that they can take good care of the patient and also provide for the safety of the community and others around that are not wearing the appropriate PPE All of this it comes as a result of education, training, and the development and maintenance of competencies. Next slide, please. So in the emergency medical services community, we adopt the same strategy that's adopted in the rest of healthcare, and that's to employ the identify, isolate, and inform strategy. So first, in any patient that has a cough and fever, applying a simple face mask, not an N95 respirator, but a simple face mask to the patient is important to help prevent transmission of an illness. In terms of identifying an individual that may have novel coronavirus, it's important to screen for travel history and the signs and symptoms that the patient may have. And this can be accomplished through processes and procedures or protocols at the public safety answering point or at the emergency medical dispatch center. If those types of protocols are being implemented, they would be done in conjunction with the medical oversight for that center, as well as interaction with the local or state public health authority for that area. Another place that we can try to identify patients is in the field by the EMS clinicians when they make patient contact. And this can be done, as has already been described, by identifying patients that have fever and cough and conducting a travel history. The specific geography that would inform that travel history will be updated on the CDC website, so we always have to keep a close eye on that. Once we identify an individual who's had a travel history that's concerning, as well as clinical signs and symptoms that are concerning, cough and fever, we need to isolate that patient just to prevent exposure to unprotected personnel. In a home, that might mean just leaving that patient in the room until the appropriate individuals can be informed and the appropriate personal protective equipment can be applied. Certainly, patients that need more urgent intervention will drive the timeline for that process. But in the identify, isolate, and inform process, it's important to isolate the patient in a way that unprotected healthcare personnel are not getting exposed. And then on that inform component, EMS agencies should have local guidelines or local protocols for notifying supervisors, and then through that process, notifying public health as appropriate. And this is important. EMS should also be communicating directly with the receiving facility, again, using local protocols, so that those receiving facilities, whether it be an emergency department or another type of facility, that their personnel can also be ready, wearing the appropriate PPE, and have the appropriate room ready for this patient, which we've heard should be an airborne isolation room. Next slide, please. In terms of infection prevention, which is so important in this healthcare workforce in the emergency medical services community, as it is with others, we try to limit exposure. It's recommended to try and limit exposure of personnel. We know that for certain types of calls, there can be 2, 3, 4, 5 different EMS personnel that are responding to a location. If we recognize that the patient has a concerning travel history and signs and symptoms, we should try to limit the number of personnel that make patient contact to the minimum required to get the job done well. With regards to trying to protect the ambulance, and this goes to modifying the environment and employing some procedures that would help decrease the likelihood of transmission, it's recommended that the driver compartment of the ambulance be separated from the patient compartment, that the ventilation system be put on high, and also to not recirculate air if that's possible, and that an exhaust fan in the patient compartment of the ambulance also be put on high. This is to ensure an adequate ventilation in that ambulance, to ensure the appropriate air exchanges per hour occurring in that ambulance. Triple K standards afford 30 air exchanges per hour, but it does require that the ventilation system is on. So separation of the driver compartment from the patient compartment and setting those ventilation systems as described is important. Of course, the healthcare personnel should apply standard and contact and airborne precautions in addition to eye protection. A simple mask should be applied to the patient, and the healthcare personnel, the EMS provider that's driving the ambulance, should, if they've made patient contact, they should doff that PPE and do that carefully and in a prescribed manner so as not to contaminate the driver compartment. But the driver of the ambulance should also wear a NIOSH-approved, fit-tested N95 respirator to guard against any droplet nuclei that might potentially be carried by the handling system to the front of the ambulance. EMS providers should be cautious with aerosol producing procedures, which we'll talk about quickly. And then the donning and doffing checklists are important to ensure that an adequate personal protective ensemble has been put on properly. And then through a prescribed process, ideally with knowledgeable observers, that PPE could be then doffed to limit the likelihood of inadvertently contaminating oneself with infectious bodily fluids. Next slide, please. Aerosol producing procedures are important to note. We do a lot of them in the emergency medical services and emergency medicine clinical environments. Administration of albuterol or other nebulized meds, airway suctioning, positive pressure ventilation like bag valve masks, CPAP or BiPAP, endotracheal intubation, CPR, they all generate aerosols. And so trying to limit the implementation of those aerosol producing procedures, as is clinically indicated, is important to try and decrease the likelihood of infectious aerosols being generated in the environment. The CDC guidance even suggests contacting medical control if feasible before conducting an aerosol producing procedure for these patients. Next slide, please. Mission recovery is important. We've already heard about cleaning and disinfection, and the same is true in the ambulance. Any visible soilage needs to be cleaned before the surfaces can be disinfected, and disinfection should occur using an EPA-registered hospital-grade disinfectant, ideally with claims against human coronavirus. Waste management, as Kate had previously mentioned, is not Category A regulated waste, but it is regulated waste. And should be handled carefully and all waste bagged in red bags as described. Durable equipment should be disinfected using the EPA-registered disinfectants. Post-mission health awareness. This is important. If you've come in contact with a person under investigation or a patient that's confirmed to have the novel coronavirus, all healthcare personnel, those in emergency medical services, but broadly, should be alert for fever or respiratory symptoms for an incubation cycle, which is 14 days. And if symptoms do develop in the healthcare worker, they should self-isolate and then through approved protocols, notify supervisors and or public health department to arrange for an evaluation. And that's important. Education and training for this is key. We believe that pre-hospital providers and healthcare workers in general should understand the illness, which is what we've tried to do here today, as well as important strategies for preventing transmission. That's an important element of a common education and training program for the EMS clinicians. Next slide, please. As is having the understanding, knowledge, and development of proficiencies for vehicle preparation, donning and doffing of PPE, understanding modifications for clinical care guidelines, waste management, medical surveillance, and a number of other items that are described on this slide. Next slide, please. There are, like I said, the information that I've provided can be found from the interim guidance for emergency medical services systems and 911 public safety answering points on this slide. There are other resources at the NETEC e-learning center in the NIEHS worker training program repository, and there's also links to the EMS infectious disease playbook that has useful reference information. Courses in awareness operator and technician level for emergency medical services providers are also available through NETEC. And with that, next slide, I will transition to Sharon to talk about other NETEC resources.
Thanks, Alex. Appreciate it. So just quickly, Alex mentioned some of our NETEC resources. We are on social media. We have our YouTube videos available. We have an online repository, so please check us out at netec.org. Again, NETEC is here to help. And so we're going to open this up. I'm going to pass it back over to Dan so that we can get some questions and answer time.
Thanks, Sharon. Thank you for all the questions that we got. Unfortunately, we won't be able to answer everything here live on the webinar, but between the panelists and some of the staffers who are assisting, we will certainly try to get answers to everybody who submitted a question either through the Q&A or through the chat. So we do have a couple that we want to talk about here, just on posing to the panelists. So Sharon, first question, you can pass this off to one of your colleagues. The first question is, it's flu season, so a lot of patients have flu-like symptoms. So the determinant factor is travel history. but what if that patient has not traveled to China, but they have traveled?
So I'll start out and see if colleagues from CDC want to add in. The CDC has developed, I think, very good PUI criteria that were reviewed on the beginning of the slide deck. The travel history is very important. If there is travel beyond the areas that are mentioned, then I think that's a discussion that you have with infection control, infectious disease, and your local public health agencies if it raises enough level of concern to contact the CDC or others for testing.
So the next question we have also kind of focuses on the CDC. Question is, didn't the CDC distribute testing kits to the states? Do those kits need to be sent back to central labs at the CDC, or are they field tests that do not require CDC lab analysis?
This is Ryan at CDC. Unfortunately, I can't answer the specifics of that. I do know that the kits have been rolled out to a number of states and validation is ongoing, but to my knowledge, specimens are still being confirmed here. Probably have to talk to your local health department about timelines for local capacity on that.
Next question focuses on patient categorization. Hospitals in the Hunan province began categorizing patients as confirmed, symptomatic, potentially exposed, or other, and have isolated these classes in hospitals and clinics. Should this same approach be used versus having patients commingle in the same waiting and treatment areas?
We'll ask
question.
CDC colleagues to answer that, please.
Yeah, so I think part of that question has to do with the volume of patients that they're seeing in China. Right now, we're operating more under a PUI, which you might think of a suspect patient definition for purposes of initial identification, isolation, and notification to public health. And then our case confirmation depends on laboratory confirmation here. I think some of the separation and cohorting type scenarios that you might be referring to would be in a larger volume patient scenario.
All right, we got time for one more question here before we wrap up at the top of the hour. What's the duration of UV exposure that should be used to disinfect items that will be sensitive to standard disinfection, paper products, for example?
Thank you. I'm going to ask Kate and our colleagues at Nebraska to go ahead and answer that question.
We actually had Dr. John Lowe answer that question online, and we're trying to find where the answer is, because he got it down specifically to, it was like 3 kilojoules per square inch or something.
Yeah,
like
it
that.
depends on your UV equipment. So we'll try to sort that out in the Q&A section there. He did respond to that.
Well, very good. I appreciate everyone who submitted questions, and we do apologize for not being able to get to all of them today. We did want to be mindful of everyone's time who gave us an hour to focus on this important topic and to give our experts an opportunity to talk about these things. So to wrap up, on behalf of ENA, ACEP, AAMC, NETEC, and the CDC, I'd like to thank the hundreds of people who signed up and joined us for today's webinar. I'd also like to offer a special thank you to our esteemed presenters and moderator, Sharon Van Aersdale. So thank you all for taking time out of your schedules, which are obviously very busy with what's going on. So thank you for being a part of this. And one of the most common questions we did get today is about the availability of these slides in the webinar. I can tell you that if you missed any part of this or you'd like to share it with your peers and colleagues, a recording will soon be available of the webinar online for on-demand viewing this week. We've encouraged all of the organizations to post it somewhere on their website or to share it through other means. I can tell you from ENA's perspective, we will have it on our YouTube channel and as well as on our COVID 2019 page on our website. So look at our social media, look at the social media of the different organizations as an avenue to figure out where this will be. And we'll work with our presenters to determine whether we can separately share the slide deck. So if you were a part of this as an attendee, we do have an ability to contact you and let you know about the availability of the slide deck itself. So once again, we thank you all for your participation in this important coronavirus disease 2019 webinar for healthcare providers. We appreciate all of your time and your questions, and we thank you for everything you offered us today. And we thank you and hope you have a great rest of your day.